This continuing education event is about mild cognitive impairment, dementia, and Alzheimer's disease. What is it? How is it diagnosed? What interventions work? The objectives for this lesson are to obtain foundational knowledge about mild cognitive impairment, dementia, and Alzheimer's disease, to describe the prevalence, disease burden, and identify risk factors and symptoms and how to mitigate them when possible, to identify clinical indicators used for diagnosis, and to distinguish the stages of disease progression, then to discuss the relationship between personhood and well-being and how the care burden impacts families, and to identify unmet needs and interventions across the disease trajectory. So let's first talk about what it is. Dementia is an umbrella term that's used for Alzheimer's disease, frontotemporal dementia, and vascular dementia. Also for dementia with Lewy bodies, Parkinson's, progressive palsy, and corticobasal degeneration. So it's a very broad term. So all people forget things from time to time, regardless of our age. As a person gets older, memory works differently, and from time to time, a person may forget something. This is common and normal. Dementia is not a normal part of aging. It's a disease of the brain. The normal state with forgetfulness refers to memory only, and it does not disturb daily life. It's about details missing of some event. Information's on the tip of your tongue, but comes back eventually, and it doesn't prevent the brain storing new information. But dementia, which is abnormal, is being forgetful, losing control of your life. Memory loss is severe enough to interfere with ability to function properly. It's impaired abstract thinking, judgment, or use of language, or its inability to perform complex physical tasks or to recognize objects or people. There are 35.6 million people worldwide affected with the Dementia Epidemic, and there are 7.7 million new cases each year. There are several risk factors for dementia. 10% is genetics, and approximately 30 to 60% is genetically influenced by inherited genes, living longer, and getting dementia. It is already known that Hispanics and African Americans are more likely to have dementia. Other factors that influence a dementia diagnosis include older age, which is for less than 65, 4%, those that are 65 to 70, 15%, and for over 75 to 84, 44% of the people have dementia. Also, if you're low income, education, or have early life events, if you smoke, use alcohol, or have low social engagement, have little physical activity or cognitive stimulation, or poor nutrition, and also chronic illness like diabetes and cardiovascular disease are all risk factors for dementia. So there are 88 million people in the US who will be age 65 or older by 2050. And 13.8 million people in the US will have Alzheimer's disease by 2050. Today, every 65 seconds, there is a new case, and by 2050, every 33 seconds, there will be a new case of Alzheimer's disease. It's a public health crisis and a growing epidemic. There's also financial burden of Alzheimer's disease. Worldwide, the annual cost of care exceeds $818 billion, and that was back in 2015. Alzheimer's is the most expensive disease in the US. The projected cost is over $1.1 trillion. Currently, the annual cost to Medicare is $559 billion, and the out-of-pocket cost is estimated at $198 billion annually. So what are the different types of disease? There are 8 types of dementia, which are listed here on this slide. Alzheimer's disease, vascular dementia, Lewy body, mixed dementia, frontal lobal degeneration, Parkinson's disease, Creutzfeldt-Jakob disease, and normal pressure hydrocephalus. There are different causes of these diseases. For Alzheimer's disease, it's abnormalities of more than one cause of dementia. It's from accumulation of protein fragment plaques outside the neurons in the brain and twisted strands of protein inside the neurons that damage or cause the neurons to die. Whereas vascular dementia is impaired judgment or planning, inability to make decisions or organizing, usually initial symptoms of disease. It's changes in cognition or difficulty with motor function, slow gait, or poor balance. It's from blood vessel blockage or damage or bleeding in the brain, like a silent stroke. And then Lewy body is early sleep disturbances, well-formed visual hallucinations and slowness, gait imbalance, and visual spatial impairments. This is from clumps of protein in the neurons. Whereas mixed dementia is from more than one cause of dementia, commonly Alzheimer's disease combined with vascular dementia or Lewy bodies. About 50% of people have mixed dementia, and it's higher in those over 85 years of age. Frontotemporal is a progressive aphasia. It's Pick's disease, or corticobasal degeneration and progressive supranuclear palsy. Early symptoms are changes in personality and behavior, difficulty comprehending language, and it develops at a younger age, usually less than 60, with 10% in 45 to 60-year-olds. This is caused from nerve cell atrophy. And then Parkinson's disease is problems with movement, slowness, rigidity, tremors, and changes in gait. 1/10 of the people with Alzheimer's also have Parkinson's. This is caused from aggregates in the deep area of the brain that cause degeneration. And then Creutzfeldt is a rare and fatal disorder which impairs memory and coordination and causes behavior changes. It's from misfolded protein that causes the brain to malfunction. And then there's simply normal pressure hydrocephalus, which is difficulty walking, memory loss, and inability to control urination. This is less than 5% of the dementia. It's from impaired reabsorption of CSF and which builds up in the brain. So how do you know if you have a problem with MCI, dementia, or Alzheimer's disease? Here are the 10 warning signs of dementia. First, memory loss that disrupts daily life. It's the most common sign, especially forgetting learned information. Others include forgetting important dates or events, asking for the same information over and over, increasingly needing to rely on memory aids or family members for things they used to handle on their own. The second is challenges in planning or solving problems. Doing ordinary things like hobbies and money matters are more difficult. Also, activities that should be done in a certain order, such as traveling or preparing a meal, are hard to do. The third is difficulty completing familiar tasks at home or at work, finding it hard to complete daily tasks, or having trouble driving to a familiar location, managing a budget at work, or remembering the rules of a favorite game. The fourth is confusion with time or place, losing track of dates, seasons, and the passage of time, having trouble understanding something if it is not happening immediately, or forgetting where they are or how they got there. The fifth is trouble understanding visual images and spatial relationships. For some people, having vision problems, difficulty reading or judging distance or determining color or contrast, or they may not recognize themselves in the mirror. The sixth is problems with words in speaking and writing. This is trouble following or joining a conversation, stopping in the middle of a conversation and having no idea how to continue, or they may repeat themselves. Problems finding the right word or calling things by the wrong name. The seventh is misplacing things and losing the ability to retrace steps. You may put things in an unusual place, lose things, or be unable to go back over their steps to find them again. Or they may accuse others of stealing, and it occurs more frequently over time. The eighth is a decreased or poor judgment. Changes in judgment or decision making. For example, they may use poor judgment when dealing with money, give large amounts to a street musician, or ordering things they cannot pay for. They may pay less attention to grooming or keeping themselves clean. The ninth is withdrawal from work or social activities, giving up hobbies, social activities, work projects, or sports, having trouble keeping up with their favorite sports team or remembering how to complete a favorite hobby, or avoiding being social because of changes they have experienced. They think of doing nothing and nothing can go wrong. And the 10th and final one is changes in mood and personality. The mood and personalities can change. They can become confused, suspicious, depressed, or anxious. They may be easily upset at home, at work, with friends, or in places where they are out of their comfort zone. These are the 10 warning signs of dementia. In summary, diagnosis of mild cognitive impairment are some deficits, but that does not affect a person's ability to function in everyday life. Whereas a diagnosis of dementia requires the presence of progressive, irreversible changes in cognition and/or behavior that impair daily function and represent a decline from the previous level. And finally, Alzheimer's disease diagnosis also includes the onset from months to years, worsening cognition, and at least 2 cognitive and behavioral impairments. So what's happening in the brain? Alzheimer's was named after Dr. Alois Alzheimer. In 1906, he discovered changes in the brain of a woman who died from unusual mental illness. Symptoms included memory loss, language problems, and unpredictable behavior. After her death, he examined her brain and found abnormal clumps, which were amyloid plaques, and tangled bundles of fiber, which were neurofibrillary tangles, as shown here in the picture. Plaques and tangles are 2 of the main pathological features of Alzheimer's disease. There's progressive loss of synaptic connection and neuronal death. Damage begins 10 to 20 years prior to symptom development. So how is it diagnosed? Diagnostic criteria were first established in 1984 and then revised again in 2011, so that it's flexible for use by clinicians and researchers. It's diagnosed by history and clinical exam, as biomarkers are not yet available. There is some beginning studies on genetic mutations with amyloid precursor proteins and apoprotein APOE4, which are not specific and are not used widely, just mostly in research. Alzheimer's can only be definitively diagnosed after death, linking the clinical measures and examination of brain tissue. Mild cognitive impairment differs from dementia in its degree of severity. Impairment does not affect the person's ability to function in everyday life, but it still should be followed up because many progress from mild cognitive impairment to developing a dementia syndrome. So it's important to diagnose MCI and be aware of beginning issues regarding impairment. All-cause diagnosis of dementia includes cognitive or behavioral symptoms that interfere with ability to function at work or usual activities and represents a decline from the previous level of functioning and performing, and is not explained by delirium or major psychiatric disorders. Labs and sometimes imaging are used to rule out other causes. Dementia is diagnosed through a combination of history taking from the person and knowledgeable informant and objective cognitive assessment like a mental status exam, MMSE or MOCA, or neurophysiological testing when routine assessment cannot provide diagnosis. When there is cognitive or behavioral impairment, 2 of the following must be found to demonstrate impairment: impaired ability to acquire and remember new information, impaired reasoning and handling of complex tasks or poor judgment, impaired visual spatial abilities, impaired languages, or changes in personality. How do you differ dementia from Alzheimer's? So Alzheimer's must meet the criteria for all-cause dementia and have the following: insidious onset over months to years, a clear history of worsening cognition by report or observation, and deficits on examination in one of two categories: amnestic, involving mainly mentation, or non-amnestic, involving other functions more than mentation. So how fast do the stages of dementia happen? There's a preclinical pre-symptomatic stage. These are physical conditions connected to dementia that exist in the body before symptoms are evident. Currently, they're only defined in research setting or clinical trials, and they're unlikely to be given an official diagnosis, but treatment should begin at this stage. And then there's the prodromal stage, where there's mild cognitive impairment. It's between normal age-related memory loss and dementia. There's persistent memory problems with name recollection, difficulty following conversations, marked forgetfulness, and they're able to perform routine activities without assistance. Mild cognitive impairment often leads to Alzheimer's disease, but not all of the time. And then there's the stage 1 mild, where there's loss of energy and spontaneity, though no one notices anything unusual. They exhibit minor memory loss and mood swings, and they're slow to learn and react. After a while, they start to shy away from anything new and prefer familiar things. They're able to perform basic tasks independently and may need assistance with more complicated activities. Speech and understanding become slower. They lose their train of thought mid-sentence, and they're lost while traveling, forget to pay the bills. As they become aware of loss of control, they become depressed, fearful, irritable, and restless. And stage 2 is moderate. Eventually, they begin to be disabled. They're able to recall distant past or recent events become more difficult to remember. It affects the ability to comprehend location, day, and time. Caregivers must give clear instruction and repeat often. As the mind slips away, it invents words and does not recognize familiar faces. And then stage 3 is severe. During the final stage, they're more and more unresponsive. Memory becomes so poor that no one is recognizable. They lose their bowel and bladder control and need constant care. They lose the ability to chew and swallow and become bedridden. They're vulnerable to pneumonia, infection, and other illnesses. Respiratory problems worsen when they're bedridden, and it can lead to coma and death. So what can be done to reduce the risk of dementia? First, prevent head trauma. Traumatic brain injury is a risk many years after its original injury. To prevent this, we can use seatbelts, helmets, and fall prevention. We can also promote heart health. There's a close link between heart health and brain health. We can modify cardiovascular risk by quitting smoking, using a DASH Mediterranean or MIND diet, and physical activity. We can also do avoidance management by preventing onset of or managing conditions that increase risk like high blood pressure, diabetes, and midlife obesity. And keeping the brain active is important with mental activity, learning new information and skills, volunteering, reading, and playing challenging games. Social connectiveness with friends, social groups, and volunteering is very important. So let's talk about person-centered care. Personhood is the central idea of person-centered care. The needs of the person are comfort, warmth and compassion, occupation, meaningful engagement, identity, sense of continuity with the past, inclusion, which means belonging, attachment, being socially accepted, and love, which is unconditional acceptance. With dementia, they have multitudes of losses: cognitive, emotional, social, physical, impacted by past traumas, disadvantages, and social dislocation. Facilitation, giving, holding, negotiation, play, recognition, relaxation, stimulation, and validation support personhood. So what do people need across the continuum of care? The desired outcome for people with dementia is to attain and maintain the highest level of function, to decrease severity and frequency of neuropsychiatric symptoms, to delay institutionalization, to promote caregiver and person-centered decision-making, to reduce caregiver stress and burden, and enhance caregiver knowledge of and comfort with dementia care. Here's the dementia framework showing degeneration leads to issues. So with neurodegeneration associated with dementia, there's changes in the ability to interact with others and the environment and disruption in neurotoxicity, which then leads to increasing the vulnerability to stressors and eventually behavioral and psychological symptoms of dementia. The person issues can include acute things like UTI, pneumonia, dehydration and constipation, and unmet needs such as pain, sleep problems, fear, boredom, loss of control, or loss of purpose. There are also environmental issues like over or under stimulation, lack of activity and structure, and mismatch with the cognitive level. And finally, caregiver issues such as stress and burden, depression, communication issues, and a mismatch of dementia and severity and expectations. This is what the unmet needs model is by Cohen and Mansfield. Underlying unmet need is causing an inappropriate behavior. It may not be apparent to a caregiver, or a caregiver may feel unable to fulfill a need like sensory deprivation, boredom, and loneliness. Ideally, it's good to identify and prevent the needs from arising to a point of causing distress. It requires proactive, person-centered approach. So here's the clinical trajectory of unmet needs. As you can see, along the line trajectory, there's normal, preclinical, mild cognitive impairment, and then early, moderate, and severe stage dementia. As you can see, there are certain clinical indicators of problems in the preclinical to mild cognitive impairment stage. This includes anxiety, some executive dysfunction, some memory loss, some IADL functional changes, and difficulty remaining engaged. Things you can do are engagement in health-promoting lifestyle behaviors, including physical activity, diet changes, social engagement, and cognitive stimulation. At the early stage of dementia, they may have emotional distress like anxiety, apathy, or depression, executive dysfunction, memory loss, IADL functional changes, disengagement in lack of meaningful activities, unsafe driving, and unemployment. Potential interventions include memory evaluation, driving evaluation and transportation, illness education, advanced care planning, medication supervision, caregiver education, IADL support, skills training and problem solving and compulsory strategy use, and care coordination skills. In the moderate stage of dementia, they may have neuropsychiatric symptoms, IADL and ADL functional changes, home safety issues, fall risk, social isolation, undetected medical conditions like pain, infection, vision or hearing changes, comorbidities, and rejection of care. Potential interventions include structured activities, behavior management, emotional support, home modification, caregiver support and skills training, and wandering and fall risk management. And at the severe stage of dementia, they may have emotional distress, pain, inability to care for self or to communicate, and poor quality of life. Potential interventions include palliative or comfort care, sensory-based interventions, and caregiver support. In summary, persons with dementia or Alzheimer's disease and their caregivers confront multiple changing challenges and needs over the disease trajectory. Challenges and needs are in large part due to a widening gap between neurodegenerative processes, declining capabilities, and increased vulnerabilities to the physical and social environment. It is possible to identify challenges and unmet needs and introduce non-pharmacological approaches to reach the 6 desired outcomes. So what are the behavioral symptoms in dementia? A heterogeneous group of non-cognitive manifestations include cognitive, behavioral, and psychological sequelae of brain disease. There's clusters of related symptoms called neuropsychiatric symptoms of dementia. It's a hallmark of the disease, and it occurs through disease progression. It's nearly universal. Almost all persons with dementia will have one or more behavioral symptoms, regardless of dementia etiology. So here they are. Depression, which is sad, tearful, hopeless, low self-esteem, anxiety, or guilt. Or agitation, which is walking aimlessly, pacing, trailing, restlessness, repetitive actions, dressing and undressing, and sleep disturbance. And then there's aggression, which is aggressive resistance, physical aggression, and verbal aggression. Or apathy, which is withdrawn, lack of interest or amotivation. And psychosis, which is hallucinations, delusions, and misidentifications. Other symptoms could include withdrawal and not paying attention, rejecting of needed care, poor self-care, unfriendliness, wandering or elopement, shadowing, or inappropriate behaviors like screaming, spitting, or sexual behaviors. There could also be activity disturbances, diurnal rhythm disturbance, affective disturbance, phobias, sleep problems like nighttime behavioral disturbances, or appetite and eating abnormalities like ingesting inappropriate materials, or aberrant motor activity or vocalization. There are many consequences of these symptoms. For the person with dementia, they have decreased quality of life, they're a burden to the caregiver, they usually have earlier institutionalization, and there are safety concerns, and it's a much higher cost of care. For the caregiver, they also have decreased quality of life, increased depression, burden, or upset, and an increased need for vigilance and time spent caregiving. There's also an increased risk of nursing home placement for caregivers, and the increased out-of-pocket and societal cost. So what interventions work for treating these types of behavioral symptoms that people have with dementia? Here's a 6-step plan to address behaviors. Highly interrelated, co-occurring steps to address behavioral symptoms which are non-pharmacologically evidence-based interventions. Step 1, are the behaviors co-occurring? Conduct an ongoing screening of the behavior. There's no standard screen, but there are 44 tools available. It could be used to evaluate pain, sleep disturbance, inadequate nutrition, and infection or other acute medical illnesses. There's some general preventative measures like caregiver education on importance of early detection of behavior and knowing when to notify a physician. But step 1 is our behaviors co-occurring. Then step 2, if a person has a behavior, to describe it. Interview the person with dementia and the caregiver to characterize their behavior. What is the behavior? Can you describe it? What did he or she do or say? Why is the behavior a problem? What about it really gets you or makes you upset? When does the behavior occur? What time of day? What days of the week? How often did the behavior happen in the past week or past month? Where does the behavior occur? Can you recognize any patterns? What happened right before the behavior occurs? Where were you? Who's around when the behavior occurs and how do they react? What is the environment like where the behavior occurs? How would you like the behavior to change? Consider the person's perspective too, and any immediate considerations like safety or the caregiver level of distress. Then in step 3, try to identify the underlying cause. Is it the individual, the physical environment, or the caregiver? For the individual with dementia, are there underlying medical conditions, executive dysfunctions, poor sleep, pain, dehydration, disengagement, risk of falls, or fear of loss of control of meaning? For the physical environment, is there clutter, noise level, visual cues, complexity, under or overstimulating, activities that are too complex, safety issues, or is it too hot or too cold? And for the caregiver, are there communication issues with yelling, harsh negative tones or blaming, expectations being too high, stress, poor health, rushes and no predictable routines seen, a poor relationship, or ineffective coping? Identifying the underlying cause will help to figure out what behavioral intervention to use. Then in step 4, devise a treatment plan. There are a lot of generalized approaches regarding non-behavior specific. They can be designed to enrich the environment, reconnect the person with dementia to the environment and previous roles, and improve caregiver well-being through education, support, and skills training. There are also targeted approaches with problem solving, designed to prevent, minimize, and eliminate a targeting behavior, and identify specific moldable factors contributing to identifiable behavior. You can also do a referral to a specialist like a geropsychiatrist, psychologist, OT, or geriatric nurse, or a combination of all of the above to devise the treatment plan. Having a plan is really one of the key steps in caring for someone with dementia. So examples of non-pharmacological strategies include ongoing support, education, and skills training of caregivers, established structured daily routines that are predictable, keep them engaged in activities matching interest and capabilities, engage in exercise like walking or gardening, or environmental modifications to remove clutter, use grab bars or a tub bench, and managing sleep disturbance. Evaluate the sleep routine, eliminate caffeinated beverages, create a structured day, introduce exercise and other activities at key times in the day, use a nightlight, and evaluate the environment for temperature, noise, light, and shadows. And then step 5 is evaluating if the plan worked. Evaluate if strategies minimized behavioral symptoms. If not working, why? Was it never implemented? Implemented incorrectly? Implemented correctly but did not address the issue? Or were there changes in the person with dementia? If it was partially effective, tweak the strategy. If it was effective, reinforce use and explain why it was effective. Then in step 6, you should have ongoing monitoring and assessment of the behavioral symptoms and risk factors, and whether the strategies continue to be effective, and if the caregiver needs additional education and support. Keep trying non-pharmacological approaches. They're relatively adverse-free. And create a health professional team to offset time needed for provision of non-pharmacological approaches when possible. So what interventions work with those with dementia? Treatment goals for individuals with dementia include enhancing and maintaining quality of life, maintaining function and engagement in activities, family support, and to medically manage comorbidities. People with dementia spend most of the day doing nothing, not engaged in activity that has meaning, And lack of stimulation can lead to isolation, dependence, poor quality of life, and behavioral and psychological symptoms such as aggression, agitation, depression, and apathy. The solution is to reduce the frequency and intensity of behavioral disturbances, to increase positive emotions and improve the quality of life. We do this to maintain a sense of personhood and connectivity. It provides continuity from the past to the present by helping people participate in previous meaningful roles. And it provides important meaning and purpose in daily life, enduring needs throughout the disease trajectory. There are many psychological benefits. Exercise maintains physical strength and cardiovascular fitness. It regulates diurnal patterns and improves sleep. So activity is one of the main solutions. Here's the clinical trajectory and use of activity. In a normal preclinical person with mild cognitive impairment, exercise is meaningful and novel. Cognitive and social activities is useful for prevention. But with early and moderate stage treatment, social, physical, and cognitive activities need to be tailored to a person's interest and abilities. And in severe dementia, you need to think about sensory stimulation reduction and use of touch and music to manage treatment symptoms. You also need to think about modifying the properties of activities. Objects and properties such as tools, materials, and equipment of an activity are important. You need to offer activities of interest and adapt materials to enable use. And think about space demands like the physical environment of an activity and adjusting the lighting or noise level to create a calm and relaxing environment. Also think about social demands. Use specific prompts and praise statements and relax the rules. There's no right or wrong as long as a person is safe. And also think about sequencing and timing. Modify steps to perform an activity. Like you could do dominoes anywhere on a board, and provide verbal, gestural, or written cues to help a person follow the steps. Introduce more physically active activities in the late morning or early afternoon, and more quiet in the evening. So timing is very important. And think about the physical environment where the person lives. It's often neglected, but often the most important consideration in dementia care. Physical environment can support or negatively impact everyday functioning, orientation, activity engagement, behaviors, safety, and community integration. Healthcare environment can put a person at risk in a care setting for delirium, disorientation, agitation, and confusion. And so can an environment in someone's home. So think about the clinical trajectory of dementia. In the normal preclinical and mild cognitive impairment phase, you need to ease the negotiating of the physical environment and think about emerging difficulties with a cluttered home or office where people can't find things. There can also be difficulties with recognizing objects and their use, navigating or wayfinding or knowing what to do when someone has moderate to severe dementia. As competencies decline, the environment does not. The environment is experienced as imposing, causing increasing demands on the individual. The impact of the cluttered environment is they're unable to choose appropriate clothing, it becomes overwhelming, and clean and dirty clothing get mixed up. And this can increase agitation and dependence in dressing. Strategies to reduce stimuli include color contrast, object placement, and using previous habits. Clutters can impact engagement too. If there's too much noise on the radio or TV, or if it's always on, if there's lack of appropriate objects for stimulation, or lack of appropriate activities for meaningful engagement. It's unclear what to do in an environment, how to effectively change if it's cluttered, and it can also be unsafe. Strategies to use to declutter include less demand, appropriate level of stimulation, and it's comfortable and calming if you declutter. The main outcome is increased independence. So reducing the clutter in an environment is very important. There are also several environmental cues to treat behaviors. If a person wanders, you can use signage such as stop or arrows. If they cannot find the commode, as it's white on white in a bathroom, you can use colored tape to locate an item. If they can't find clothes in the morning, you can label the pertinent objects like cabinets and drawers to help them find their clothes. If they have poor hygiene, you can set out items to cleanse and organize the items by task to simplify it. If they have distraction, poor eating, and malnutrition, you can use a red placemat with a white plate and one food item and a single spoon to reduce the distraction, to improve eating and prevent malnutrition. And if there's safety issues, some of the strategies you can use are tape on each step on having railings or bed railings, and a control center with the needed objects in one location like their meds, their food, and their phone. And also activity engagement in a safe manner. These are all environmental cues with behaviors associated to them with strategies that are evidence-based and proven to work. So in summary, the physical environment is often a neglected therapeutic agent in dementia care. Designing the environments to fit capabilities and needs results in quality of life improvements. Environmental redesign principles such as simplification, decluttering, use of assistive devices, color contrast, removal or purposeful placement of objects, and labeling with words or pictures are helpful. Modifications can enhance wayfinding and orientation, reduce functional difficulties of the person with dementia, enhance abilities of families to provide efficient and safe care, and reintegrate persons with dementia at home and in the community. Helping people with dementia effectively interact in their home and community environment is an important part of designing a comprehensive dementia care plan. There are also some useful technological advances for those with dementia. Cell phones with large buttons increase accessibility. IVACs increase IADL independence. Integrated systems to maintain independence safely with med reminders, remote monitoring, socialization features, and health sensors have been known to be effective. There are also several caregiver support apps. You can increase safety by using door and bed alarm sensors to alert caregivers of wandering, GPS sensors in shoes to detect wandering, motion detectors on the door, window, toilet seat, and push-button switches to help caregivers remotely monitor well-being. There are apps or assistive devices to locate a person. Medication adherence dispensing alarm reminders or locking sections so that people can't get at their meds are also very effective. And valves to automatically prevent scalding from hot water technology. There are many advances in technology that can help people manage with dementia. So what to do at the end of life, and what is palliative care? Palliative care palliative care is important to those with dementia, but there are many barriers. Dementia differs from other causes of death because it's a prolonged median survival time, generally 4 years and up to 9 years in some people. Clinician and caregiver difficulty in viewing dementia as a terminal illness, even in the late stages. And current hospice enrollment criteria poorly restrictive of the terminal phase of dementia. Treatments for comorbid conditions in dementia often are difficult to surrogates, or to forgo. So people keep treating the comorbid conditions. Healthcare systems promote burdensome treatments, and pain management is challenging, and behavioral problems are frequent, and caregiver stress can be overwhelming. All of these are barriers to palliative care in those with dementia. But palliative care is a philosophy and structured system for delivering a care. It expands traditional disease model to include goals of the person and family to engage in quality of life, to optimize function and help with decision making, and can be delivered with life-prolonging care or as a focus of care. A clinician can discuss advanced care planning while the person's able and has the capacity, and provide expert clinical medical care and symptom management, and refer to the community for other resources. The person can get their affairs in order and do advanced care planning, and the family can help the person adjust to the diagnosis and make plans for the future. Frank discussions of prognosis empowers the person and family to establish goals of care and make treatment choices while the person has the capacity to do so. It's important to have these conversations early in the phases of dementia. There's also a care burden associated with dementia. 83% of care provided to older adults is by family members, friends, or other unpaid caregivers. And 70% of the people with Alzheimer's disease live in the community. There are over 16 million caregivers with 18.5 billion hours of unpaid care, valued at $233.9 billion. 2/3 of caregivers are women, typically a daughter or wife. They're middle-aged, over 50, and employed. Caregiving responsibilities include help with activities of daily living, medical and financial management, and providing increasing levels of care as the disease progresses. There are many challenges for caregivers, which include physical, psychological, and social changes. It's approximated there are $11.8 billion of additional healthcare costs. 60% rate emotional stress as very high or high, and 30 to 40% suffer from depression. There's increased likelihood of new or worsening health problems. There are also work challenges. 57% went in late, left early, or took time off. 18% went from full to part-time work. 16% took leave of absence, and 8% turned down the promotion, while 1 in 6 quit work entirely to be a caregiver. Caregiving lasts a long time with someone with dementia. 86% last at least 1 year, and 50% are 4 or more years. It can range from 4 to 20 years. And the burden of care is the highest for dementia caregiving. The role of health systems could not sustain the cost of care without caregivers. We need support for caregivers as a public health issue. It currently does not exist. Caregivers need support groups, wellness programs, care services, including in-home care, so they can have relief and time off, and legal and financial services, residential care, transportation, and adult daycare. Most of these do not currently exist in most communities. In summary, Healthy People 2030 states objectives for Alzheimer's and dementia care are increased diagnosis and awareness, and to reduce preventable hospitalizations, and increase the number of older adults discussing their memory issues with a healthcare professional early in their trajectory. Dementia systems need support services and workforce training and education, And we also need dementia-friendly communities that are safe, supportive environments. These are all goals of Healthy People 2030. There are also issues with the workforce and caregiver training. There is some education and informal training for both groups, and there's benefits and importance of early detection and diagnosis. Also, cognitive health risk reduction. We also need to do training in how to address physical, cognitive, and emotional behavioral symptoms, and how to manage comorbidities, and the types and availabilities of resources and supports. We also need training in how to address stigma, abuse, and advanced care planning. There are some resources such as case management, respite, and support groups, but not enough to address caregiver burden, needs, and self-care. These all remain issues today. Understanding the disease and how it impacts the person with the disease and their family is the first step in designing comprehensive care to enhance the quality of life of all concerned, both the person with dementia and their family and caregivers. For more information, you can log on to the Alzheimer's Association website, the CDC Alzheimer's Disease and Healthy Aging Program website, or the National Institutes of Health website. They're updated regularly with cutting-edge, evidence-based information. Thank you for listening.